welcome. Thank you for joining us today for our webinar entitled Advancing Maternal Health Through Simulation, Stories of Success and Survival. My name is Alyssa Lapierre, and I'm the Product Marketing Manager for our Maternal and Pediatric Solutions here at Laerdal Medical, and I will be your host today. So it's an absolute pleasure to be with you all here today. I know we have a big group of us. If you ever have to drop off throughout the meeting today, please feel free because we will be sending out a recording of today's session, but hopefully you can stay on with us throughout the entirety. So we have a really great, vital, and timely topic today, as you can see from the title. And I do want to do some introductions before we move in. So at Laerdal, as you might know, our mission is to help save lives, and we're deeply committed to advancing patient survivability through innovative simulation solutions, as well as our partnerships. In this session, we will be exploring how simulation-based education and training are making a transformative impact in reducing maternal mortality and improving patient outcomes overall. Over the next hour, we'll dive into some personal stories, some practical applications, and success stories from healthcare professionals who are leveraging simulation to enhance their care delivery. Should we have time at the end, we will open up for a Q&A. That's given if we do have the extended time, if you want to stay on with us towards the end. However, you can feel free to drop your questions in the chat as we go along, and our speakers and team can help answer those in the chat as well. So to kick things off, I do want to introduce our esteemed speakers who will be sharing their expertise and insights into this critical area of healthcare. So starting with Helen, some of you might know Helen, some of you might not, so I will give her a nice introduction. Helen has been with us at Laerdal Medical for about 10 years now and has contributed to our mission of helping save lives. As the Marketing Operations Associate for our North American team, she plays a key role in supporting healthcare initiatives and simulation initiatives. Helen is deeply passionate about advancing simulation in healthcare and improving patient outcomes. She will be sharing her story with us today as it relates to her case with preeclampsia. And really, this story will serve as a reminder that there's always a person and a family behind the numbers and statistics that we will see today. Next, we have Dr. Veronica Gillispie-Bell, who is a board-certified obstetrician and gynecologist and section head of the Women's Services at Ochsner-Kenner in New Orleans. She directs quality for women's services across Ochsner Health and specializes in heavy menstrual bleeding and minimally invasive surgeries. She's a national leader in maternal health equity, and she serves as the medical director of the Louisiana Perinatal Quality Collaborative and Pregnancy-Associated Mortality Review. She advocates for improved birth outcomes and racial equity, and she's also been featured by some major media outlets, some of which you might be familiar with, such as USA Today, the New York Times, and Good Morning America. She's also testified before Congress. So we're very excited to have her here with us today to talk about implementing quality improvement tools in simulation and in drills that can really help save lives and improve outcomes. Moving into our final segment today, we are so pleased to have Carol Fuller with us. She is the Systems Director of Nursing for Women and Children's Services at Bronson Healthcare in Kalamazoo, Michigan. She brings with her over 40 years of leadership experience in nursing and is a passionate advocate for health equity. She also works to support families of color and advance magnet and baby-friendly designations. Carol holds a BSN and an MBA and multiple professional certifications. She not only has that, but dedicates her time to serving as a sexual assault advocate. So I'm extremely pleased to welcome these three ladies with us today as they bring us through a journey of maternal health and how we can improve those outcomes. Before we move into our first segment, I did want to outline some of today's learning objectives that you can expect to take away. Firstly, we're going to be discussing the state of maternal health in the United States after we hear from Helen's story. We will discuss how postpartum hemorrhage can lead to maternal morbidity and mortality and identify evidence-based steps to improve those outcomes. We will discuss how simulation-based education can improve outcomes, describe the learning accomplished through simulation in a regional and community hospital setting, so a specific example, and describe the real-life impact from simulation training. We will also experience not only the provider and nursing leadership's view, but the patient's view through Helen's story of the impact of simulation training in maternal outcomes. So with that, I will pass it over to my colleague Helen, who will talk about her story.
Hello, everyone. And Alyssa, thank you for that warm introduction. And thank you for allowing me to be part of the conversation today. I'm very honored that you asked me to share my story. 7 months ago, on April 29th, I welcomed a beautiful baby girl via VBAC. I was so incredibly proud of myself, and my entire team of doctors and nurses were as well. In fact, they even clapped after the successful delivery. I was in labor for about 34 hours. For 12 hours, I was convinced that I was having Braxton Hicks since my contractions weren't consistent. It wasn't until I finally went to the hospital that I realized that I was 6 centimeters dilated. After getting the epidural, I got Pitocin. The baby then decided that she wanted to kick back and relax from that point on, which caused concern. She was so relaxed that nurses constantly had me switching positions using a peanut-shaped ball. I'm sure many of you know what that looks like. I'm not sure if it was that increased movement or what, but at some point during labor, my blood pressure spiked. This did not cause too much concern as I was being closely monitored by a great team of nurses and doctors. After I had a successful delivery, I moved over to my post-delivery room, and things were going great from that point on. I was able to get discharged the next day. However, while I was being discharged, one of the nurses mentioned that I would be going home with a blood pressure cuff to be monitored over the next few weeks. I was a little taken aback because I wasn't sure why I even needed that when I never had a history of high blood pressure. But the nurses were quick to remind me that my blood pressure was high at one point while laboring, and that was enough to raise concerns for hypertension. Honestly, I was really surprised because I had a very healthy pregnancy and I've literally never had any issues with my blood pressure. So hearing that I had to monitor my blood pressure was quite a shock. Nonetheless, I did it because I knew they wouldn't ask me to do that for no reason. When I got home, things were great. I felt great mentally and physically. As instructed, I started monitoring my blood pressure. The blood pressure cuff was part of a program used to reduce maternal mortality rates at this specific hospital. Anytime I used the cuff, a team of nurses received my reading, and in the event there was an abnormal reading, they would contact me and then contact my doctor directly. They asked me to monitor my blood pressure daily. So while at home, 3 days went by with normal readings, but this morning was a little bit different. I was lying in bed and decided to check my blood pressure, which probably was a mistake. The reading came back at 160 over 105. When I saw that, I immediately jumped out of bed, scared. My husband then instructed me to sit down properly and do the reading again in 15 minutes. 15 minutes later, it came back at 150 over 103. At this point, I started to panic. While being discharged a few days prior, I was told that if my reading came in around 140 over 90, then I would have to come back to labor and delivery for an evaluation. And honestly, that was the last thing that I wanted. So I decided to try to take my blood pressure one last time. And I just knew that time it was going to be different and that I'd have a normal reading. But nope, that was not the case. My blood pressure came back in at 156 over 104. Before I could even process what was happening, I got a call from a nurse who instructed me to get to the hospital ASAP. So I got the baby, grabbed my husband, and we did just that. Once we arrived, I saw the entire team of healthcare professionals who took care of me while I was in labor. They were all very concerned that I was back, and one by one, they would come up to me and ask if I had any symptoms. Did I have blurry vision? Did I have a headache? Did I have swelling? Was there pain in my belly? Nausea, shortness of breath, and so on and so forth. I told them all that I felt fine and that I thought I looked fine too. One of my labor nurses stopped by and looked at my feet, and then she looked over at my left foot and said that it looked swollen. But I was in such denial, and I was pretty convinced that it was my Birkenstock sandals that were just way too tight on my feet. So I told her that that was what the issue was. So a few hours after checking in, I was getting examined, and my blood pressure was still very high. A team of doctors and nurses came in to explain what was happening and what the next steps were. At that point, I was diagnosed with severe preeclampsia. So I was scared. I'm not gonna lie, I was very scared. I'm usually pretty strong, but I felt very weak and vulnerable at that moment. I remember crying as I tried to unpack my diagnosis and what that could mean for me, for my family. I didn't know what was happening, and didn't know if I was going to be okay. But the one thing I did know was that I was in good hands and that I needed to just trust the process. After the initial evaluation came a blood pressure pill to help regulate my blood pressure, then an IV pull, and tons of monitoring equipment. I had a catheter put in since I was about to be in for a long ride with a treatment plan of 24 hours of magnesium. Once I started on the magnesium, I felt okay. I still didn't have any preeclampsia symptoms that I noticed. Everything seemed fine until a few hours in when I started getting a headache. That headache ended up being so bad that I told my nurses that I thought I was going to have an aneurysm and that they were going to have another problem on their hands. My headache got significantly worse with every noise I heard, the peak of light coming in, and pretty much whenever anyone came to check on me. I was on a liquid diet, so I couldn't eat to relieve the pain. But it was then at that point where one of the nurses gave me Motrin, and I was super excited, but that did nothing for me. So I started shivering and I was covered in blankets at one point. And after a while, the nurses came in and applied a blood circulation machine to my legs since I was just lying in place. This helped me warm up quite a bit, and believe it or not, it actually made me feel a little bit more comfortable. A few hours in, I started experiencing blurry vision. It was so bad. It was so bad that I couldn't even look at my phone or even read a book. And honestly, I felt like somebody had a tub of Vaseline and just covered my eyes with it. At this point, I was swollen, I was hungry, I had a splitting headache, and I had blurry vision. My baby and my husband were with me the entire time, but I could barely feed her or interact with them because of how sick I felt. A few more hours in, my nurse took me off the liquid diet and gave me Tylenol. Once that happened, I started feeling significantly better. Things started taking a positive turn. The entire time I was under magnesium, my blood pressure was normal, so things were moving in the right direction. I continued doing great, and as I approached the end of my 24-hour magnesium treatment, my vision became clearer and my headache went away. My swelling also went down. When the doctors came in to tell me that I could go home, I was ready to jump out of bed. But it wasn't that easy. I still didn't feel 100%, but they cleared me to leave, and I continued my recovery at home. It took me about 3 days to start feeling like myself again. While I was at home, I continued to monitor my blood pressure for another 2 weeks out of precaution, and thankfully, everything was normal. So while I was in the hospital, I had an incredible team of nurses and doctors who explained everything to me and made me feel as comfortable as I possibly could. Although it scared me and there were several moments of uncertainty, I truly trusted the team and I knew that their process was possibly saving my life. Who knows what would have happened had I not been given that blood pressure cuff to monitor myself at home. I'm very grateful to the labor and delivery team at Washington Hospital Center here in Washington, D.C. Give them a little shout out. They have a great process in place, and I was recently reading data from this hospital that shows that 68% of patients who were sent home with that same blood pressure monitoring system that I was sent home with, they actually used the cuff when they got home. And what's more is that 100% of those patients that were advised to come to the hospital for blood pressure treatment, they actually ended up getting medication. So that brings me to the end. And thanks for listening to my story. And thanks to all the healthcare professionals who are out there making a difference in your patients' lives. You're truly helping save lives. And I'm a living testimony of great care. Thank you.
Thank you so much, Helen. That's honestly such an amazing story, and thank you for your bravery in telling it and sharing it with our audience today. I know that this really speaks volumes to the processes in place and the nurses and the doctors that made you feel comfortable and safe in that environment, and also your experience with preeclampsia that could be resonating with some people in the audience right now, and definitely with us that know you very well. So not only the protocols, but the emotions, the symptoms, the trials that you went to, and now you have your two beautiful baby girls that we see in the photo there. So thank you so much for sharing. And I hope that resonated with you all in the audience today. If you do have questions for Helen, please feel free, to put them in the chat. She's going to be with us for the remainder of the session today. But yes, thank you so much, Helen. And our next speaker will actually be discussing a little bit more on the medical side of things when it comes to these hypertensive and postpartum complications that really will help us illustrate the state of maternal health in the US. So without further ado, I will pass it over to Dr. Gillespie.
Thank you, Alyssa, and thank you, Helen, so much for telling your story and for just being very transparent about how you felt at that time. I think it's important for us to hear as healthcare providers from the patient's perspective, what works and what things our patients need in order to be able to get to improve our health outcomes. And Alyssa, you can go to the next slide. And so just to start us off, as we talk about the didactic portion of this, I just want to ground us in where we are with maternal morbidity and maternal mortality in the United States. When we look at maternal mortality, we in the US are higher than any other high-income country. And you can see if you look at the bottom of the slide, this is from Commonwealth from 2024, you can see where other high income countries are in terms of their maternal mortality rate. And the US is much, much higher than that. I think the other part that's important to know is that globally, maternal mortality rates have been declining. But in the US, over the last 30 years, year over year, the maternal mortality rate has increased. So we're really moving in the wrong direction. In addition to what you've seen from that data from 2020 that was released in 2024, the rates were even higher during the pandemic. You can see that total population looking from 2018 through 2021, that the rates went from 17.4 per 100,000 births all the way up to 32.9 per 100,000 births in 2021. We did see the numbers come down a little bit in 2022. But if we look at that in total, they came down in 2022 compared to 2021, because 2021 we had a significant spike due to maternal deaths related to COVID. So if we just compare 2020 to 2022, the rate was higher even in 2022 compared to 2020. So again, still moving in the wrong direction. Not only do we have maternal outcomes in the US that are not where we want them to be, especially compared to other high-income countries, we also have disparities. So if we look at the data from 2016 to 2018, we see that Black women are 3 times more likely to experience a pregnancy-related death. American Indian and Alaska Native women are twice as likely to experience a pregnancy-related death. So again, our rates of maternal mortality in the US are not where we want them to be, and we have segments of our population that are suffering even more. And then even as we start to adjust for socioeconomic factors, for Black women, we still see a disparity. A Black woman with a college degree is twice as likely as a white woman with an 8th grade education to experience a pregnancy-related death. And so that makes us really have to look at how we are providing care to our patients in the US. Now, if we look at just looking at 2017 to 2019, and then also at 2020, in addition to the rates that we saw from 2017 to 2019, in 2020, the rate was actually the highest for our Native Hawaiian or Pacific Islander women. Now, the denominator was much smaller compared to our other races, but suffice it to say, there's a disparity. So again, we have not good outcomes in terms of our rates, but we also have racial disparities looking at many ways, looking at for our Black patients, looking at our American Indian, Alaska Native patients, but also our Native Hawaiian, Pacific Islander patients. So looking at disparities in a different way, if we look at the non-core or what would be the rural population, our pregnancy-related mortality ratio is actually the highest in our rural population. And I just want to unpack that for a minute to think about what that means. So we have a report that comes from the March of Dimes that's called Nowhere to Go, that talks about our maternity care deserts. So over a third of our country is considered a maternity care desert, meaning there is no OBGYN, there is no midwife, there's no birthing facility. And so certainly our places that are rural are more impacted by those maternity care deserts. And then we see that in those deserts, we're actually having the worst outcomes. So as we think about maternal mortality and we think about how we address the rate and the direction that we're taking, we have to really, again, look at the data in all these ways and think about what is happening in our rural population, that we are also not having those number of providers, and what can we do to make it safer for our patients that live in those populations, in those areas. So moving beyond the numbers. So what I gave you, or what I've presented so far, were just the numbers, just the raw data when we look at death certificates. So the way we identify maternal deaths, we look at death certificates that have a pregnancy check box that's indicated. So those are what we've shared, are just raw numbers. When we look beyond the raw numbers, that's where we really lean into our maternal mortality review committees. As was mentioned, I'm the medical director of our MMRC here in Louisiana. So what MMRCs are, we are multidisciplinary committees that review pregnancy-associated deaths, meaning the death of an individual at the time of pregnancy up to 1 year of the end of pregnancy. But we're looking beyond those numbers to understand what is driving maternal mortality. So we are looking at a number of things. We're looking at medical records. We're looking at autopsy reports. Sometimes we're looking at police reports. But we're looking at a lot of information so we can understand what is causing maternal mortality, and then how can we prevent these deaths? How can we change this trajectory? And so what I'll show you on the next slide, this is the data from 38 MMRCs looking at 2020. I think what's most important to see here, and I think Helen, and given her story, is a good testament of things that we can do to prevent this. But when we look at our deaths, the majority of deaths are not happening during pregnancy. They're happening after delivery, up to 1 year postpartum. 47% of pregnancy-related deaths occurred from 7 days to 1 year postpartum in 2020. And you can see even 16% were right there in that first 6 days. And that's why it's so important that we have programs like Helen mentioned that she received at the hospital that she was cared at. And then we have a similar program at Ochsner with our Connected Mom, where we are doing things to make sure our patients are connected to care during that postpartum period, because that really is the time when they are the most vulnerable for experiencing a maternal death. So looking at the underlying causes, and these are the clinical causes, actually the leading cause of pregnancy-related deaths based on this 38 MMRCs is maternal health conditions. Now, maternal health conditions encompass, I said maternal, mental health conditions. That encompasses mental health conditions such as depression, suicide, but that also encompasses substance use disorder. But not far behind mental health conditions, we see cardiovascular conditions, which can be related to hypertension. We see infection, hemorrhage, embolism, and then specifically hypertensive disorders of pregnancy, followed by amniotic fluid embolism. So again, understanding what the clinical causes are that are contributing to our pregnancy-related deaths, so we know where to design those solutions. And so we're spending a lot of time talking about maternal mortality, and talking about those deaths, but I think we always have to remember that maternal mortality is just the tip of the iceberg. For every case of a maternal death, there are 60 to 70 cases of severe maternal morbidity. And so as we think about when we're trying to improve our maternal outcomes in the US, we are trying to prevent deaths, but really we want to target morbidity. And as we improve our severe maternal morbidity, that also improves our mortality. And so when I talk about severe maternal morbidity, just to put this into context, in the United States, we have about 2.5 million uncomplicated deliveries, 1 million near misses, 60,000 severe maternal morbidity cases, and then 800 cases of mortality. So again, as we think about improving maternal outcomes overall, yes, we want our maternal deaths to increase, but we really, in some of the things that we are doing and some of the solutions are really trying to target severe maternal morbidity. Next slide. So what can we do? It can feel very overwhelming looking at these numbers, seeing these trends, seeing the disparities. And so if I could put it into a Venn diagram, if I could put it, I did put it into a Venn diagram of what those solutions are. It really is these overlapping 3 big areas: addressing our social determinants of health, improving our systems of care, and improving clinical quality of care. It is a Venn diagram because you cannot do one without the other. Really, all 3 we have to address simultaneously, and we have to do all of that through a lens of equity. If we don't do it through a lens of equity, we will see our disparity gap get even further. Now, today we're going to focus on improving clinical quality of care, but again, thinking about the big picture, it really is addressing all 3. So as we think about improving clinical quality of care today, in particular, we're going to talk about obstetric hemorrhage and hypertension. We could talk about a lot of clinical conditions based on our maternal mortality, but let's talk about obstetric hemorrhage and hypertension. This is also where I've spent the bulk of my time, areas of focus on in my time of being the medical director of quality for women's services at Ochsner, but also the medical director of our perinatal quality collaborative. So why hemorrhage? So obstetric hemorrhage remains one of the leading causes of maternal mortality worldwide. So if we look beyond the United States and we look across the world, obstetric hemorrhage is still one of those leading causes. And we see that rate increasing. If we looked from 2000 to 2019, and this is in the US, we see that the rate of hemorrhage increased from 2.7% to 4.3%. So a significant double or a significant increase in the rate of obstetric hemorrhage. But I believe, because some of the things that we are doing from a readiness, recognition, prevention, response standpoint, that we really can improve outcomes. I say that because even though the rate increased from 2.7% to 4.3%, looking from 2000 to 2019, in that first segment, 2000 to 2011, we also saw blood transfusions increase. But if we look 2011 to 2019, we saw that the blood transfusions decreased. And I really think that's because of some of the guidance that we have started to get from the Alliance for Innovation on Maternal Health around 2015, 2016, those things being put into place, I think is why we're seeing those outcomes improve, even though the rate of hemorrhage is increasing. So when I say, so moving on to other causes, and then we'll get into specifically into hemorrhage, but thinking about hypertensive disorders of pregnancy, and again, this I think needs to be at the top of mind, especially when we're thinking about Helen's story. Hypertensive disorders also is one of the leading causes of maternal mortality worldwide. And if we look at the rate of hypertensive disorders of pregnancy, it has increased significantly. From 1989 to 2020, the rate increased from 2.8% to 8.2%. So the rate has and not on this slide, the rate has increased for hypertensive disorders of pregnancy at a rate higher than that of chronic hypertension. So if we look at the general population, there's only been about a 0.3% increase in chronic hypertension, where it's been a much greater increase for our pregnant population. And again, thinking about that, and there's lots of things that have contributed to that. One is that we know our maternal age is increasing. So the age that we're giving birth has increased. And then we also have other factors that are increasing in that. But regardless, because we want to improve our outcomes, we have to focus on readiness, recognition, prevention, and response. Same as for hemorrhage if we want to improve our outcomes. So I keep saying readiness, recognition, prevention, response. What am I talking about? So we have what are known as the AIM patient safety bundles. So the Alliance for Innovation on Maternal Health, this is an initiative that is housed under the American College of Obstetricians and Gynecologists that's focused or funded by HRSA. And so with AIM, there are several maternal health safety bundles. There are bundles for hemorrhage, for hypertension, for care of individuals with substance use disorder, cardiovascular conditions, many different bundles. Each of the bundles are founded in the 5 R's. So readiness, recognition and prevention, response, reporting and learning systems, and then respectful, equitable, and supportive care. Respectful, equitable, and supportive care is woven into all of those R's. Because really, as we think about equity and improving those disparities, we have to always be thinking about that respectful, equitable care in all that we do. Readiness is talking about what do we need to do to be ready each and every time for these clinical scenarios. Recognition and prevention means what do we need to do each and every patient so that we're ready for these clinical scenarios. And response means what do we need to do each and every unit to have in place to have improved outcomes. And the reporting and systems learning is how do we look at data to know if we're improving outcomes or if outcomes are not improving, what's working, what's not working, and then also thinking about that multidisciplinary approach. I, as an obstetrician, when I take care of a patient, it's not just me taking care of the patient. It's me taking care of the patient. It's the nurse taking care of the patient. It's the anesthesiologist taking care of the patient, and so on and so forth. So that when we think about how we improve outcomes, we need to all be working together on drills, on simulation, on developing the policies, the protocols, the procedures. And so the AIM bundles really give us a great guidance for how we do this, what we need to do from, again, a policy standpoint, a procedure standpoint, what are the evidence-based practices that need to be put into place to improve our maternal outcomes. Next slide. So the other thing that we see when we talk about simulation, and we talk about, again, I kind of mentioned it with those patient safety bundles, because simulation is a part of that making sure we're doing the reporting and the learning systems. There are other entities that also understand the importance of simulation. The Joint Commission released perinatal standards. These were published in 2020 is when they came out. I actually was on the committee that helped to develop these perinatal standards. And we understood that as much as the bundles are great at telling us what we need to do, what things we need to have in place, we have to practice those things. We have to not wait just until we have a patient to make sure we have the right things on the hemorrhage card. We can't wait until we have a patient to know if we're doing the right things for timely treatment of hypertension. We have to go through multidisciplinary drills. And so the Joint Commission understands that and understands that this is a way to reinforce knowledge. So it is a requirement of the Joint Commission perinatal standards to conduct drills at least annually to determine system issues as part of ongoing quality improvement. And the rationale is basically, as I've said, that multidisciplinary drills give an organization the opportunity to practice skills and identify system issues in a controlled environment. I will give you just one example from my own experience around doing drills. I was practicing at a hospital and our women's services was moved to a new hospital. So we broke off from the main hospital and women's services was moved to a different campus. So after we got there, we said, you know what, we probably should do a code blue drill. So we did a code blue drill to just make sure we had everything in place. What we found, it was an unannounced drill. Now, the security and the administration said, could you please in the future just let us know if y'all are going to do a drill? But we wanted it to be real life. So we did a drill for code blue. And what we found out in that particular site, because again, we were moving to a new site, it's different than where we had come from. At that site, the ICU nurses were the ones that would run the code card on a code blue. Well, guess what else we found out? The ICU nurses, their badge wouldn't even let them into the labor and delivery unit. So thank goodness that we did this drill to understand what things need to be in place. Who was going to be the one that runs the code card? Who was going to be the one to run the drill? Who comes to the drill? Does the ED come to the drill? Is it the OB anesthesiologist? Who's going to be the one to give the medications or give the orders for the medications? Again, thank goodness we did all of this because we had a code blue, a real code blue about 2 months after that, and we had already worked out those kinks. And so things went so much smoother than if we had not done this drill and this simulation. So simulation is really important, again, as it says here, to understand what is happening in that system, not only from a medical knowledge place to be able to practice those skills, but also identify those systems issues. From the medical knowledge standpoint, I think it is hugely, hugely important to do drills and simulations. We mentioned for a couple of reasons. We mentioned that a lot of our mortality is happening in the rural population. In the rural population, we also tend to not have as many births. So the numbers are much smaller. So that means that some of these really what we call high acuity events become very low occurrence. They're typically low occurring even in higher level facilities, but in a rural facility, they are really going to be low occurring. So high acuity, low occurrence events. And so we really, really need to constantly do drills so that we can make sure we're remembering all of the steps, that we have that medical knowledge, because it's not something that we see every day. And I know for me, at my own institution, as well as the work that we do with the Perinatal Quality Collaborative, we've seen the benefit of doing those drills. Next slide. I think I probably already said some of the things I'm going to tell you on this next slide about why simulation. Again, we have a higher retention of knowledge, which is important, even if it's something that you're doing commonly, but you may not do every day. It's important to do drills so that you have that higher retention of knowledge. This is what the literature data shows us, that doing drills, we have that. It's a safer space to learn from mistakes. It's so much better to be in a controlled environment, as I mentioned with our code blue, to know not only the kind of the systems that needed to be in place to be able to run that code, but also little things like remembering, we had to remind the ED staff, remember for pregnant patients, you have to put a wedge under them to displace that uterus if you're going to do chest compressions when we have a cardiac arrest. And so it's a safe space for us to all be able to say what's working, what's not working, and to evaluate skills. We can give real-time feedback on knowledge and skills. So whether you're using a high fidelity simulator or you're doing low fidelity with a checklist, we are able to provide that feedback. I know when we design simulations at my institution, we have a checklist for what we expect of the doctor, what we expect of the nurse, what we expect of the resident physician if they're involved. And so after that simulation, we're able to then give that real-time feedback so that each of us is able to learn from each other, learn what we're doing well, what we need to improve on, but also what each of our roles are in those different simulations. It gives us that opportunity, again, to practice on high acuity, low occurrence situations. And again, as I said, it allows for that team building. And so in summary, maternal morbidity, mortality is a public health emergency. It's a public health crisis, but we can improve outcomes through readiness, recognition, prevention, response, and that reporting, all through a lens of equity. Simulation is so important. It provides us that opportunity to assess clinical skill and knowledge, and it's in a safe environment. It's very real when you're going through that simulation. There are things that I know we are always doing to make it feel like it's more real, which is great, but it's safe, and you are able to make those mistakes and learn from them. And then simulation is possible regardless of resources. Again, whether you have a high fidelity monitor or you're creating a very low fidelity with a low fidelity monitor or low resource situation, simulation is possible and is necessary. And I will turn it back to you, Alyssa.
Thank you so much, Dr. Gillispie-Bell. That was incredible. I hope everybody has taken away some piece that they can bring back to their center or bring back to their teams. Again, if you do have questions, we do have the chat open, and I can try to make sure we have time at the end to cover some of them. But without further ado, we have Carol, who will be actually presenting some of the real life impact of simulation. So we talked about the state of maternal health. We saw the patient's perspective with Helen's story, and now we're going to move into some of the real life impact of sim training, and that through data, through participant feedback, and more. So I will hand it off to you, Carol.
Thanks, Alyssa, and thank you, Laerdal, for inviting us to come, and all three of us to come and make this presentation. And it's interesting listening to Dr. Gillespie and Helen. We feed into each other pretty well here, I think. So it's a great opportunity. My talk is going to be a little bit more about what our experience has been with the Laerdal simulation. And I want to give you a little background about my health system. But first, let me say, if you're from Hawaii, please don't put in the chat what your temperature is right now, because it's 30, feels like 20 here in Michigan. So definitely know that you probably have better weather than I do. We are a 9-county region health system in Southwest Michigan. And we have 2 hospitals within that system that birth. One larger hospital, which births about 3,700 a year, with a regional network and a level 3 NICU. We are a level 4 maternal level of care facility. For our other facility, it's a smaller, more community-based hospital. I need to update the slide, I guess, because this year we're going to hit 900. But we are a community hospital with just a level 1 nursery, going after a level 2 maternal levels of care with the Joint Commission. So very different 2 facilities and very different needs related to simulation. All of us, I think, would agree that those who have larger facilities have a lot more resources available to you. And those who have the more rural and community hospitals, as Dr. Gillespie talked about, have a lot less resources to really be able to do simulations in a way that is actually going to meet the needs of the staff and the providers. So if you go to the next slide, I want to talk a little bit about what simulation did for us and our patients. First, we met with Laerdal and actually understood what the program really was and what the options were. We made a very conscious decision to offer our simulations in real life locations. So we actually did our simulations on our units, right in the middle of our units in the middle of the day. And we actually did them throughout all of our shifts. We did a 4-day simulation at our larger facility and trained over 200 staff and providers. That is pretty much difficult for most of us to do with the resources that we currently have. We actually heard from both our providers and our staff that this was an amazing opportunity. Initially, we did the simulation at our smaller facility because we felt they were the ones with the greatest need and had the least amount of resources to run big simulations. Our larger facility has residents, in-house physicians, the level 3 NICU, and we said, well, you know what? I don't know that they need simulations more than the drills we're already doing. So when we ran the first ones, what we heard from our physicians was, really, I can't believe that we do this many steps in the process, even before I as a provider come into the room. I had my chief physician say, next drill, I want to be in the room beforehand so I can see what everybody else is doing before they called me into the room. Because we know in real life, the physician is generally not at the bedside when the crisis happens. It's the nursing staff at the bedside, the residents at the bedside, the family members at the bedside, who oftentimes, as Helen did, raise the flag to say something's wrong and something's not going well. By the time we bring the physician in, we've already done a number of things to try to improve the process. We also found that it was amazing, and Dr. Gillespie had the same experience. I don't know if that's a good thing or a bad thing, but shortly after holding our simulation in our larger facility, we had a nightmare experience, but it went very well. And I'll share a little bit about that from one of our providers' views in a moment. Staff's comments, though, were what I felt as a leader and as a senior leader in our organization really made a difference because we had been doing drills. This wasn't our first time of starting drills. But the way Laerdal does their simulation, they bring in state-of-the-art equipment. They set it up very realistically. The mannequin actually talked to the staff. That freaked them out the first time until we coached them on. That was okay. We even had the Laerdal facilitator say to one of my providers when he said to the facilitator, okay, the fundus is firm now. And the facilitator said, no, it's not. And it was like, oh, okay, let me keep going and do something else then. So it was really good for the staff to see that interaction and how people communicate in those kind of scenarios. Doing it in our own space made so much of a difference. When we had to go find the blood warmer in our smaller hospital that uses a blood warmer very infrequently, we found it was hidden behind a crash cart. It took a little while to untangle that process, but now it's no longer there. So using real life made a difference. In our larger facility, we found that charge nurses were the only ones who could get into the blood refrigerator. But as we know, and that particular day, we were very busy, of course, on the unit. That always is the way it is. And my charge nurse was actually the bedside nurse in the simulation. So she wasn't available to go get the blood. So we've had to change the process, doing it in your real space, doing it in real life, walking through everybody's roles together made a huge difference and a great opportunity for us to learn. I would encourage anyone who's doing simulations to bring their senior staff to the bedside. We invited our chief nursing officer, our chief operating officer, our chief medical officer to come by, stop by, and observe a simulation. And two reasons. One, I wanted them to see what the teams really do. But I also wanted them to understand how important it is to invest in this kind of work. And they were amazed at how the team worked together, how many steps there were in the process. We ran both drills of hypertension and hemorrhage, and it did make a real impact to them. Made it a whole lot easier for me when I decided to ask for a little more money the next year to do more simulations. The debriefs that Laerdal did with us, the videotaping of the team, really allowed them to say, see, there wasn't a lot of readback in this scenario. People didn't speak back to people. So we had a near miss on a medication because someone didn't know the medication had just been given and they ordered it again. So it was a great learning opportunity to really take a step back and say, wow, what did that teach us? Really, communication at the bedside is absolutely key to the success. But what it's really about, as Helen described, is how do we make a difference for our patients? Because simulation is great and it's great training, but does it make a difference? So I'm going to have to go to the next slide, Alyssa. This story is available on Laerdal's website, so I'm not going to read this for you entirely, but one of our providers actually after the simulation and after about typical Monday night in our emergency department and our high-risk OB unit, we had a patient come in that truly was one of those experiences none of us really want to have. Preeclampsia, severe features, very high blood pressure. Shortly after being on the unit, she went into full-blown seizures, already was on MAG. We had to rush her back for a CT. We had to take her to emergency C-section. But I will tell you the experience this provider felt of the teamwork that people had because they had gone through these scenarios together, and together is the answer. It's really about bringing your whole team to the bedside for practice. Nursing's done simulations a lot before. We have sim labs all over the country. Many hospitals have large sim labs, but doing the simulation in your own unit, in your own space with your team right there, made a world of difference in how comfortable my team was in handling this very near disaster situation. We had a hemorrhage patient after our most recent one that had a very similar outcome and story that really went just so much better because the staff had drilled. One of the important things, and I'll move on to the next slide, about doing drills is what do you learn from it? Because although drills are great education, were there takeaways? How do you know if what your team is doing is better or worse than what the standards are out there? So I know this is a very busy slide, and the next one will probably look a little busier, but what I really wanted to show here was this is the kind of data that Laerdal provided me for my teams after the simulations. Providers are very data-driven. My senior executive team is very data-driven. They want to know what makes a difference. So being able to say, with our simulation training outcomes, here are our performance scores compared to other hospitals that Laerdal has worked with across the country. It really does allow you to celebrate your teams, look for your opportunities, and really dig deep into what you can do to make it better. If you want to move to the next slide, Alyssa. As I said, my smaller hospital, Bronson Battle Creek, has done 3 simulations now. They were the first to get started. And what I really like about this is that you can see year over year, time after time, improvements. ACOG alignment, very, very important to our providers and to our risk management staff and to all of us to make sure that we are meeting the standards that are out there and are we complying. And you'll see we increased our score from 4.4 of 5 to 4.7 of 5. And this is my community hospital. This is the smaller of the 2 facilities. If you look at our blood ordered, we have now are at 100% ordering it correctly. And we engage our blood bank in the simulation. So our blood bank is actually sending up the blood to us, the fake blood that Laerdal provides for the simulation, but they were very interested in being part of it. They wanted to time how long it took for them to get the blood to the floor and were we actually meeting the needs. There's a lot more data on these sheets and I'm not going to go through all of it with you, but just let me say, this is what helps drive the work we do. And also, how we as senior leaders can help our organizations see the benefits. Because if we can drive the quality, which is what it's all about, driving the quality to improve outcomes. This is what our senior leaders want to see. You can see our uterotonic administration went up from 70% to 89%. This is the kind of data people want to say, okay, did we spend that money wisely and should we spend it again? This really helps us. Next slide, please. One of the overall things that I think is most important about quality improvement with simulation is what do you do with what you learn? Because it's about getting your teams together after the simulation and celebrating our successes, but also saying, okay, we brought in an organization who is definitely at the top of their game for the standards that are necessary for this work. Now, what did they see that we might not have seen? Because we all know when you bring someone in with different eyes, they see different things. They look at our policies and procedures. They look at our process. And so these were, from my most recent simulation, some of the 4 considerations that they recommend we look at. Policy revision regarding our mag sulfate, reinforcing the establishment of role identification early in an emergency. It works, but it needs to happen sooner, considering the addition of a timer in the room. These are just very simple things, not huge changes, but they are about what you do with the information you get. Because just doing a training and have everybody go, okay, we're done, now we don't have to do it again until next year, is not really quality improvement. And it's not what you want your team to really see it as, but rather, what did we learn? What can we improve? What did we do well? How can we celebrate it? Because we all know it's important to celebrate with our teams. We want them to know they're doing better. Our team in Battle Creek just was elated to see their scores side by side, to say, look how much better we are now than we were a year and a half ago. It was a great opportunity for them to really reward themselves for the work they had done, but for us as leaders to be able to recognize and reward them as well. And then say, now, how can we get better before we simulate again in another 6 months? The first simulation we did, as I said, was in our smaller hospital. My larger hospital said, oh, we don't really need it. I invited several of the key players from my larger hospital to come and observe the simulation in Battle Creek in my smaller hospital. And they left saying, why didn't you set this up for us too? And I said, oh, okay, we can make that happen if you'd like now. But I think it is about people really understanding that this isn't just a, fun little game of simulation. This was real life. And I know one of the Laerdal reps will tell you we laughed a little bit. I was standing in the hallway outside the room that was being used for simulation, and we were talking about the process and the schedule and so forth. And about that time, one of the staff from inside the simulation where the door was closed poked their head out and said, "Carol, go get us warm blankets." And I thought, okay, off I go. I'm going to go get warm blankets for you, because it was really about driving that realism into the work of the simulation. So thank you, Laerdal, and all the work that you do to really make a difference in our communities, and for the work that Dr. Gillispie, you're doing with really helping us understand the degree of magnitude of this. We participate as part of Michigan AIM, and definitely feel this is the work that needs to be done and the work that needs to continue. And Helen, for sharing your story, because it is about the outcome and how it impacts our patients every day. So thank you. I'll turn it back over to you, Alyssa.
Wow, thank you so much, Carol. That was a great overview, and I appreciate you sharing the stories from your center and really what simulation can do from not only the data perspective, but the reactions and the feedback from the teams. So thank you so much. And you wrapped it up really nicely by thanking all the other speakers. So thank you again, Dr. Gillispie. Thank you, Helen. Another thank you to Carol. I do want to mention that we are obviously done for right now. I will check to see if there's any questions that we can answer in the last 2 minutes. But you will receive an email follow-up with the link to the recording if you wish to rewatch any of the portions or the whole thing, or share it with a colleague. Definitely let us know if you like this type of content. We can certainly put something together again. So let me just head over to the chat, and I'm sorry I haven't been watching it until just now, as I've been deep in the presentations, but seems like everyone is saying thank you. Hopefully some answers were replied to. I see some replies in the chat itself, so that's great.
Alyssa,
Yeah.
Dawn put in the chat their experience of even involving their lab folks
Mhm.
and simulating some blood draws and getting them engaged. And that is definitely what we saw too, is our ancillary departments, who generally don't get pulled into simulations, really enjoyed being brought in and being felt that the work that they do also is making a difference. So Dawn, thanks for sharing that.
Yeah, great share. Thank you. Someone wrote, and this might be a question I can take. Is there a way to get the slides? We usually don't share the slides afterwards. We could see if there's any opposition to that. However, again, we do send the recording, so technically you can go back and rewatch everything, but we usually don't share the actual PowerPoint, as some of it is copyrighted by our presenters. So I hope that answers the question, but you will get the recording. Yes, I'm asking about the simulation templates. ACOG bundles are available for free and include recommended simulation templates. So that's a great share. Excellent presentation. I agree. Will there be a follow-up in the products that Laerdal has to offer for OB scenarios? That's a great question, Michelle. In our follow-up email, we talked a little bit about high fidelity simulators versus low fidelity. So we've actually, in our follow-up, have both options in case you're curious to learn more. We do have a brand new obstetric simulator, so you can learn about that, as well as some of our lower fidelity global health products that are really great starting points to get into simulation and really drive that with a lot of different teams. So definitely. And if you have other questions, you can always reach out to us again. Thank you everyone for your participation, and I hope you were able to network through the webinar today and appreciated the content.